Good afternoon, all of you. Myself, Dr. Prateek Garg. So the topic we are discussing is deviated nasal septum. By the definition, we know we are talking about the nasal septum, which is present in the midline separating two nares. Sometimes it is deviated to one of the side. So what is the most common cause? Most common cause of DNS is considered birth trauma. So during the birth, if you talk about the vaginal delivery, because of some trauma, some pressure changes, it may get deviated. What are the other causes? Then developmental deformities of the palate. Some patient are having the habit of doing the fingering in the nose. Some are having some history of road traffic accident, fall from the bed, or hit over the nose. So these are multiple traumatic factors which can contribute to deviated nasal septum. Along with that, there may be developmental deformities of the palate. So this picture is showing various type of the nasal septum deviation. First one is anterior dislocation, where the anterior most part of the septum is deviated towards one side. It is not resting over the maxillary crest. Ideally, it should be like that. Ideally it should be resting over the maxillary crest, but in this patient, as you can see, it is dislocated towards one side. Next is C-shaped deflection, where we can see a C-shaped deviation of the nasal septum is there. Third one variety is the S-shaped. You can see this is a S-shaped deviation. S-shaped deviation. Okay. Fourth one is nasal spur. It is a sharp pointed spur which may impinging on the inferior turbinate. So nasal spur. Then comes thickening of the nasal septum. We have seen the patient, maybe because of the earlier traumatic history in the childhood. Sometimes what happens, ideally the nasal septum, the septal cartilage should be one layer, but because of the trauma there are 2 or 3 layers of septal cartilage present, giving the appearance of the nasal septum thickened, and this thickening will again restrict the airway, nasal airway. What are the clinical features? Most of the patients are asymptomatic. Only 4% patients are having symptoms. What are the symptoms? Firstly, nasal obstruction. Then comes headache, sinusitis. Headache may be because of the blockage in the drainage of the sinuses. Then bleeding from the nose, that is epistaxis. What is the cause of epistaxis? If patient is having sharp spur, suppose like this sharp spur, so what happens? The blood vessels at this area become very much fragile, leading to epistaxis, and it is a clear-cut indication for the septoplasty. Then what are the other clinical features? Anosmia, that is impaired or loss of smell, external deformity of the nose, middle ear infection because of the blockage of the eustachian tube. Then turbinate hypertrophy. This is a compensatory mechanism by the body if the DNS is there. So opposite side of the inferior turbinate that get hypertrophied. So another term is there, Sludder's neuralgia. What do you mean by Sludder's neuralgia? It is also known as ethmoidal neuralgia. What happens is sometime because of like concha bullosa or a replacement of the middle turbinate, it put pressure over the anterior ethmoidal nerves, and because of that pressure, patient is having constant headache at the area of the ethmoidal region. And if we do the CT scan of that patient, we will see the sinuses are clear, but still pain is there. So we may think of the Sludder's neuralgia, that is because of the pressure of middle turbinate over the septum, or we can say over the anterior ethmoidal nerve. Now, how to check whether the nasal wall is patent or not? So we do is the Cottle test. How to do the test? This is a nasolabial fold. Okay. So what we have to do, put the 2 finger and just retract laterally this nasal wall. Okay. So what will happen? Because of this lateral pulling, patient will feel better breathing. Nasal wall will becomes open. So that is a test to show the patency of the nasal wall. Okay. This is Cottle test has been asked in the exam. Now, when to advise surgery in a patient of deviated nasal septum? If patient is having deviated nasal septum, you can do the surgery No, generally we don't do. We do the surgery only if patient is having symptoms related to nasal obstruction or sinusitis or the previously mentioned symptom. So if patient is symptomatic, then only we will advise him for surgery. If patient is having the history of recurrent sinusitis because of the blockage of osteomeatal complex as a result of deviated nasal septum, in that case we can go for the surgery. Then epistaxis, patient is having nasal bleeding and the cause by nasal endoscopy we find out that there is a sharp spur. In that case we can go for the surgery. Then nasal obstruction which is not getting better on the medications, then in that case also we may need to correct the septal deviation. Now, two types of surgeries are there. One is the SMR, that is submucosal resection, and other one is a septoplasty. So what are the differences? SMR is generally a radical surgery where we remove complete cartilage and the bony part, whereas in septoplasty only the most deviated part of the nasal septum, whether it is cartilage or the bone, is removed. SMR generally not done below 17 years, whereas septoplasty can be performed after 4 years. Why SMR is not done below 17 years? See, what happens in the nose, nasal ossification centers are there. So if we do before 17 years, if we do the SMR in a child which is less than 17 years, so what will happen if we remove all the cartilage and the bone? So these ossification center will also get removed. So this will hamper the maturity of the ossification center, and this will hamper the normal shape. The deformity may result in saddle nose or some sort of deformity in the nose. Now, in SMR, what we use is Killian incision, whereas in the septoplasty, we use the Freer's incision. Killian's incision, it is generally mucocutaneous junction, 5 mm beneath that. SMR cannot correct anterior DNS, whereas septoplasty, it can correct anterior most DNS, that is a caudal DNS. In SMR, both sides of mucocaricondyal flaps are elevated, whereas in septoplasty, only one side of mucopericondyal flap is elevated and only the most deviated part is being removed. It is SMR, it is radical removal of the cartilage of the bone, whereas septoplasty, only the most deviated part, or we can say inferior strip. Rhinoplasty, rhinoplasty incision cannot be combined with the SMR. Whereas in septoplasty, you can combine along with the rhinoplasty. Revision surgery, it is difficult for SMR, whereas relatively easy for the septoplasty. In the SMR, the cartilage graft can be harvested, whereas in septoplasty, it is tough to harvest the cartilage graft, which can be used at other procedures. Complication, SMR having more complications, septoplasty it is having rare complications.